Welcome back. Today we're digging into a really fascinating and honestly a pretty important puzzle at the very heart of treating bipolar disorder. And that puzzle is, sometimes, the treatment that gets prescribed just isn't the right one.
So let's really dive into this. You go to the doctor, you get a prescription, and you just assume, right, that this is going to help. But what if it's not? What if, for some people, it's actually a step sideways, or maybe even a step back? This is such a critical question when you're talking about managing one of the most challenging conditions in mental health.
Now, bipolar disorder is incredibly complex. It's not something doctors just, guess at. To navigate all this, they have this amazing tool. Think of it like an expert's rulebook that pulls together decades of research to point them toward the best possible care.
Yeah, these things are called clinical practice guidelines, or CPGs for short. And they're packed with info from tons of research. They say, hey, use this, it works. But, and this is the key part for us today, they also have a big section on what not to use. And that do not use list, that's where things get really interesting.
All right, so let's get right to it. What's on this do not use list according to experts from around the world? We're going to break it down by the different phases of the illness.
Okay, so when someone's in an acute manic episode, those really intense highs, the guidelines are pretty much in agreement. They say to steer clear of certain anti-epilepsies, meds often used for seizures, things like lamotrigine by itself, or topiramate and gabapentin. The reason? It's simple, really. There's just not enough proof that they actually help with mania.
But now, let's talk about bipolar depression. This is where the story gets, well, a lot more complicated. You'd think, depression, use an antidepressant, right? Seems obvious. But for bipolar disorder, it's not so simple. The guidelines draw a really important line in the sand here.
And here's why. It all comes down to the type of bipolar disorder. For bipolar 1, giving someone only an antidepressant is a big no-no. It's risky. It can literally flip a switch and push someone from depression straight into a dangerous manic episode. But with bipolar 2, the highs are different. They're less severe, so the risk of that switch is lower. That's why some guidelines say, okay, maybe you could try it as a second or third option. It just shows you this is absolutely not a one-size-fits-all deal.
And hey, it isn't just about antidepressants. A bunch of common antipsychotics are also on the list of what to avoid, but specifically when they're used by themselves to treat the depression part. The evidence just isn't strong enough for them as a solo act.
This table really pulls it all together, summarizing warnings from 29 different international guidelines. And you can start to see these patterns, right? Gabapentin and topiramate pop up again and again, flagged because they just don't seem to work for mania or for long-term maintenance. And look at this last one. It's super important. Valproate is a big one to avoid for women who might become pregnant because of the risks. This highlights a critical point. It's not just about what works, it's about what's safe.
Okay, so we've got this expert rulebook, and it seems pretty clear. You'd think everyone would just follow it, but what's actually happening out there in the real world is, well, it's a paradox. There's this huge gap between the evidence and what's being prescribed.
Just let that sink in for a second. The use of treatments that the evidence says to avoid isn't just happening. It's becoming more common. So this isn't some old problem that's slowly getting fixed. No, the gap is actually getting bigger.
In this chart, wow, this shows it in black and white. We're looking at the use of antidepressants alone for bipolar disorder in the US. Remember, that's the thing the guidelines warn against, especially for bipolar 1. And look at the jump. It more than doubled in about 15 years, going from under 18% to almost 41%. That is the paradox right there on the screen.
So this really is the big question, isn't it? If the science and the expert guidelines are all saying avoid this, why are prescriptions for it actually going up? What is going on here?
All right, let's try to crack this code. Researchers have dug into this, and they've pointed to 4 main reasons that help explain this gap. It's not just one thing, it's a whole mix of issues.
Okay, let's break this down. First, there's just not enough clear information. The guidelines themselves can be super confusing. Plus, there's this weird bias in research where it's easier to publish studies that show a drug works than one that shows it doesn't. So doctors might not even be seeing the full picture. Second, you've got marketing influence from drug companies. That can definitely shape prescribing habits. Third, there's simple human bias. A doctor might have had one patient who did well on a certain drug and thinks, hey, maybe it'll work again, even if the data says otherwise. And finally, and you can't ignore this, the illness itself is just so complex. Sometimes a doctor is facing a really tough case. They've tried everything, and they just want to do something to help. It really is like a perfect storm of different factors.
So, the big question is, how do we bridge this gap? The good news is, we're not stuck. There are actually some very clear, practical steps we can take to get things back on track.
It really all comes down to making the evidence easier to access and use. Create clear, simple guides for clinicians who are incredibly busy. Use the same language everywhere, so not recommended is crystal clear. We've got to make sure the whole story gets out there, the good and the bad trial results. And we need to draw a firm line between real science education and a sales pitch. And maybe most importantly, encourage doctors to review each other's prescribing habits to keep everyone accountable to the best evidence.
And that really gets us to the ultimate goal here. This isn't about doctors getting a bad grade for not following the rules. This is all about one thing: making sure patients get the best possible outcomes. It's about preventing treatments that are unsafe or just plain don't work, because better information, it really does lead to better care. So it leaves us with this final thought, right? To get the best care is knowing what to avoid just as critical as knowing what to choose. It's something for everyone involved, patients, families, doctors, to think about. It's a powerful reminder that in medicine, where the first rule is do no harm, sometimes the wisest choice is knowing when not to prescribe something. Thanks for tuning in.